All right, guys. Hey, today we're going to be talking about post-arrest care. We're going to go through the algorithm, A, B, C, D, E, how we get through the algorithm for post-arrest. So what is post-arrest? We had a cardiac arrest. We got Ross. We got pulses back. We're on the way to the hospital now. Your job is just starting. The next 20 minutes is super critical. So we get some stuff done. I like to use this algorithm because it makes sense to me, but it also works. One of the reasons because it works head to toe. Yeah, I address the things as I go head to toe, so it makes it easier for me to remember. Okay, so airway first for our A. Okay, so all things airway, kind of quickly to go through them. If you don't have an advanced airway in place, you should, but if you don't, for whatever reason, we either need to determine that we don't need one or we need to get one. Okay? Advanced airway being an iGel or an ET tube, we need to get that secure before we get to the hospital. Right, and secure that airway. For whatever reason, they were in arrest and now they don't need to be intubated. It could be possible. Okay, make sure that at minimum we suction that airway really well. We have some type of oral adjunct in there to keep their airway open and keep their tongue secure, and that we're able to ventilate them properly with airway. Okay, so how do we verify that tube? Right, so end-tidal CO2, so airway. ET tube, just gonna put ET tube, right? End-tidal CO2 is how we verify that. If we don't have an end-tidal reading, we already really messed up anyway, but if we don't have an end-tidal reading, we need to get one. We need to get it plugged in. We need to make sure that it's still good. And we need to look at that, how that end-tidal cleft looks, and to make sure we don't have any problems with our tube. Okay, next we use end-tidal to verify the tube in the beginning. This is a really good time to check those breath sounds again and make sure during the process of moving around and during the rest, the tube hasn't moved. Okay. If I right main stemmed them, I only verified with end-tidal CO2. I don't know that they're right main stem. This is a good time to check breath sounds on both sides and adjust the tube. Okay. Make sure that the tube is secured. It needs a tamer. If it doesn't have a tamer, it should get one. Okay. Almost no reason why you shouldn't use a tube tamer. If you just have it taped to the side, quick, cool. This is the time where we fix that. Get the tamer in place. Intubated patients need C-collars. This is a good time to put them in a C-collar. Go ahead and put that C-collar on so that you don't have that tube, their head flop around, the tube moving around. Right, head blocks, they can be optional for this, but I found that if you're gonna use a C-collar on an unconscious person, probably use head blocks. Keep their head in, good and in place. All right, so all things airway. Next, I'm just gonna write suction up here, because that's important. I talked about it a little bit earlier. But do they have a tube? Have you verified that tube? Is it secured with a tamer? And anytime we get a tamer, what's the depth? We'll say 27 at the teeth. Good time to check that. Got a C-collar, got head blocks, suction them out really well. Our airway is solid. Got a good solid airway. Okay. Breathing. Next. Okay, so I move from their mouth down to their chest for breathing. All right, so breathing. Next step, A, B. B stands for breathing. Moving from your airway, right in your mouth and head, down to your chest for your breathing. This is whenever we end-tidal CO2 comes into play right off the bat. We've already checked it. What's our end-tidal looking like? As far as what level is it at? How many ventilations are we giving? What are we using for our ventilations? Are we BVMing still? If we're still using the BVM, we want to switch to the ventilator. We want to get its settings set. Okay. If we haven't already, we're going to be at the same time end-tidal, the same time the end-tidal. We're getting an SpO2 reading, so I want to know where their oxygen's at. And I want to switch them over to the ventilator. If they're already on the ventilator or they're on a lot of oxygen, I'm going to check that SpO2, and if it's doing good, I want to adjust that oxygen. I want to try to get them down to 21 if possible, but usually 40 is a good range, 40% O2, but not 100% O2. I don't want to have them on 100% still and be breathing out through the ventilator and have them at a 100% concentration of oxygen and 100% of the SpO2 at the same time. Not good for you. So we want to titrate the O2 and get it set in a good setting based on what we're seeing with our patient. How is our end-tidal? What's that pleth look like? Is the air going in and out easily? Good. what is the my ventilator settings, etc. And then and my SpO2 allows me to titrate my oxygen. Put them on that ventilator, gives them more precise air. I'm not giving them too much through the BVM, gives them a precise amount. Things that go on with your breathing. All those things, super important. If this was a respiratory call, okay, it started as a respiratory call, and that end-tidal CO2, I'm seeing shark fin waveform, good time to start a breathing treatment on the way to the hospital. Okay, so anything breathing wise. Next, circulation. Moving down, I like to think about circulation moving from your breathing to your heart or from your breathing to the IV, or where you check a pulse. I think of it like that. So next, circulation. Start right off the bat. What are our vital signs? Okay, what is our blood pressure? It's going to be our main vital sign we use for circulation. What's our initial blood pressure that we're getting? Okay. If we don't have a good solid blood pressure, then we need to address that. Look at it right away. We're going to look at doing a fluid bolus for that. But in order to do a fluid bolus, back up even further, we get a blood pressure. We had an IO during the arrest that we used. Now we need IVs, because now we need to give medications and drugs quickly. So we need IVs. By IVs, 2 of them. We need 2 large bore IVs. Okay, preferably in the AC. AC in hand or AC in wrist, forearm, etc. will do, but we want 2 large bore IVs. Okay. Once we get one of those IVs established, we're going to look at giving a fluid bolus to address this blood pressure. Okay. We've already given one on the code, and that's probably empty, and we've probably forgotten about it. The one that's on the IO is probably empty. We probably forgot. Let's get that changed out. In case we need to push more drugs through the IO. If we have an IV now, we can take the bag off the IO. We don't need it anymore. Switch to the IV, get a fluid bolus going. Okay, 500 is probably a good place to start. We've already probably given 500. Look at what our blood pressure is. Give another 500. Next, circulation. Addressing circulation is anything to do with the heart. Starting with blood pressure is most important. Okay, fluid bolus, and then consider Levophed. Okay. You should have watched a video a few shifts ago about Levophed, so you know how to use it. But consider using Levophed if my fluid bolus isn't working. Next, circulation. Okay, on the vital sign, what's our heart rate? Is SpO2 heart rate good enough? Not now. We need to put a 4 lead on and monitor the cardiac monitor. Okay, and now I need to see what rhythm they're in. Okay, I probably had the pads on before, and I can run off the pads. That's okay. But by throwing that 4 lead on, if I need to pace, now I can pace. Without the 4 lead, I can't pace. So if we especially have a low heart rate on our pads, let's get that 4 lead on. Okay. Take a look at our circulation. This is another good time to the next thing. Anybody that went cardiac arrest had at least some form of a cardiovascular problem. Okay, so this is a good time to do a 12 lead in case they had a STEMI. Okay, so circulation, things to think about: blood pressure, 2 large bore IVs, fluid bolus. Also checking the one that's on the IO. It's a good time to think about it. Pushing the fluid bolus to an IV, checking the bag that's probably empty on the IO, getting rid of it. Consider Levophed, check a heart rate, get a 4 lead and a 12 lead. Okay. Circulation. ABC. If we just get that done, good to go. ABC is the most important. Next 2, these things are extra things to think about, and they do really help later on. Next one I like to call it deficits. By the book it's called deficits. Deficits are damaged. Like I like to think about it. This is a good time to look at what happened. Okay. 12 lead, the last thing we did on circulation, addresses this as well. But if we haven't done 12 lead, this is the time to do it. Okay. Probably had a STEMI. So there's a good chance. So this is a good time to do a 12 lead. Okay. What kind of other deficits? Is there obvious neural deficits? Like is one pupil blown out? Right? We're assessing for any deficits. Neuro would be a good one. What's the level of sedation? Did you use anything to tube them? You shouldn't have. Did you use anything to tube them? Like Versed, ketamine? After you got Ross, did they start to wake up? Is there any purposeful movements? Right? Looking at that stuff. Those sorts of damage that was done. This is a trauma. We got him back from a trauma code. I said, damage. Start dealing with that, or they're going to go back into arrest. E, next, environment, expose, and extricate. Okay, I added the extricate in there because it kind of makes more sense with firemen. Okay. First thing's environment. Thing to think about, hypothermia. Okay. Basically, as we've been learning here over the last year, every patient that is in cardiac arrest is in some level of hypothermia. We don't want it to get any worse. Plus, we gave them a lot of fluids. Depends on what the temperature is outside. Depends how much blood they lost. If it was trauma code, et cetera, et cetera. So, we should have already exposed this patient, but we want to make sure that we take them out of whatever environment that they are in. So if they were in the house and it was cold, or outside and we're working it, get them out of that cold environment now, and we transport them. If it's truly, we believe they're hypothermic, then use active warning procedures with heat packs in the groin and the armpits. Expose. Okay, if they weren't exposed already, if you didn't do it during the code because you're in a hurry, this is the time to do it. Get their clothes cut off, their shirt and their pants cut off, and get them where you can see everything. You can assess them better, find out if there's anything going on. Okay? So we're just going to call that trauma naked. Everybody's pretty familiar with that term. And then extricate. Okay, so extricate. What I think about with extricate is when we get to the hospital, we have to extricate the patient from the ambulance to the ER. Okay. I used to just put ER on here, thinking about getting ready to go to the ER. I've changed it to extricate for fire purposes. It makes sense to the firemen. But we got to extricate this patient once we get there. It's really difficult to, if all this stuff that we put on wasn't put on in any type of semblance of order, right? And everything is wadded up everywhere, and we still have old IO bags, and we got the bag that's hanging on this side of the ambulance going to the IV on this side. So all of that stuff, head and toe sweep, needs to be fixed. Okay? Make sure that your ventilator is starting at the head. I have to go inside. Make sure that your ventilator is on the cot. Make sure that the oxygen is no longer hooked to the wall and it's hooked to the portable oxygen. Okay? Make sure that your ventilator tubing is not wrapped around anything, so that when you pull it out, it rips it out of their mouth. We go to their chest. They're right back down. Make sure that the 4-lead cables are not wrapped around everything. If you took the 12-lead, you don't need it anymore. Take it off. Get it out of the way. Okay? If your pads are on there, okay, make sure that it's not wadded up and hooked to something. Okay, twisted around an IV, etc. Check those IVs. Make sure those IVs are secured. Okay, they shouldn't be Kerlexed so tight that their hands are turning purple, but they also just can't have a techoderm on them and no tape. They got to be taped and secured. Make sure those are taped and secured. Make sure that they're Kerlexed, whatever you like to use. Make sure that's secured. Make sure they're flowing well, all that. The IO, the IV fluid, if you push the bolus and there's nothing left, or you get to the hospital, don't take it inside. Disconnect it. You're gonna move 3 mils of fluid in that 50 yards. Nothing's gonna change. That doesn't change anything. Okay? Get rid of it so you don't actually rip your IV out. What could change the patient's care dramatically is losing an IV and not being able to get a new one. But the 3 mils of fluid that you're gonna move in that time period aren't going to. If you're afraid they might need them inside, they don't really use our stuff anyway. But if you're afraid they might, or it has to stay on, leave it on. But if you're afraid they might, leave it on the cot. You can hook it back up. But disconnecting if you're not using it actively is a great idea. So we've got them exposed. We've fixed everything now. We've made sure that nothing's tangled. Everything's ready to go. The monitor's on the cot. The ventilator's on the cot. The oxygen's on the cot. The patient's all set up. We can fix all those straps that we messed up. Okay. Get those nice and straight. Get our side rails up. Get everything ready to go. Get the patient packaged and ready to extricate. Use a sheet. Cover the person with a sheet right before I wrap them up. That way that I got everything all nice and put the sheet on them. Lock your straps on. And now everything's kind of cocooned. I can take them inside, take the straps off, move the sheet, move the patient, okay? If we were smart, we put a mega mover or a sheet down on the cot to assist moving them. Those blue sheets don't work real well when you have all that stuff on them, right? They're too heavy. So move them across, nice and easy. Everything was nice and secured and cocooned together, so it comes across nice and easy. We have good continuity of care, good transfer of patient care, right? So post-arrest, man, the basics of it. We just kind of walk through it, pretty easy. Go through systematically with your algorithm, A, B, C, D, E, and then head to toe for your extrication. Get ready. Last thing on extrication, which we did hit up a little bit. Once you get them inside and you extricate them to the hospital, you gotta give a report. Okay, so all that stuff that you did, you gotta know. So have that stuff ready. Have everything ready to go in your glove or however you like to do it. Have a plan. I'm gonna get in there and I'm gonna tell them this and I have my stuff. Okay, so that's part of extricate. Once extricate, I have to give a report. That's all I got for you for post-arrest. If you got any questions about this, there's several videos about this on the YouTube channel already. This is kind of the down and dirty ABCs you want to cover today. If you're more interested in it, give me a shout. Talk to me. If you got any questions, concerns, comments, etc. If not, thank you. Appreciate your time, and I'll talk to you guys soon.